3, 2, 1, you're live.
Good evening, everyone, and welcome to the 6th Conversation That Matters series in collaboration with the HSE. This evening's conversation will finish at about approximately 10 minutes past 7, and we are inviting our audience to put any questions you may have to the panel. There's a small icon at the end of your screen, so if you would type in your question, my colleague Tina Joyce will be collating questions throughout the course of our conversation, and she will put them to the panel towards the end of our conversation. My name is Caroline O'Regan. I work with the Institute of Leadership in the Royal College of Surgeons in Ireland. I am very pleased to have the opportunity to continue our discussions about the impact of quality in this COVID-19 crisis. This is a really important and complex area and is particularly challenging in this pandemic. I would like to warmly welcome our panel of experts this evening. Dr. Miriam Colleran. Miriam is a consultant in palliative medicine with St. Bridget's Hospice and Naas General Hospital. I would also like to welcome Professor Donal Brennan. Donal is Professor of Gynecological Oncology at UCD and the Mater Hospital in Dublin. I would like to welcome back Dr. John Fitzsimons. John is a consultant paediatrician with Temple Street Hospital in Dublin and also a clinical director for quality improvement. And finally, I would like to welcome Dr. Philip Crowley. Philip is a national director in a very senior leadership position with the Health Services Executive in Ireland in the quality improvement team. Our 4 panel experts are joining us this evening to talk about quality in this pandemic in a very general sense. I'd like to remind our viewers of our discussion last Thursday when we talked about the social impact and how families were coping in the COVID-19 crisis. We covered the restrictions of the impact on core assumptions and predictability, especially around the world for children, the never-changing solace of routines like going to school and meeting friends. I suppose the natural order has now been shattered. We also explored the whole cultural ritual norms that we have celebrated for decades and how this has all changed overnight. Specifically, we looked at funerals and gatherings, things we take for granted, not being able to hug or grieve a grieved friend or a family member. It brought us into the conversation around isolation, social distancing, and visiting restrictions on families, and not only COVID-19 families and patients. A colleague, Dr. Kevin McCarthy, kindly shared his story about his father, a patient who had suffered a stroke. He said it was a very strange time for him, an adult child, a son, a doctor, and finding it challenging trying to come to terms with being the rational doctor in terms of decisions that he was making and taking and suppressing his feelings. He talked about how he had to put aside his rational thinking and his training as a doctor and just allow himself to feel the feelings and the full range of emotions, the worry, the concern, the love of a son for his dad. He spoke about his style of managing and leading his team and his approach to care for patients, which was fundamentally a compassionate approach, and how that has helped his team and across teams to maintain their spirit and positivity throughout this crisis, and ultimately has an impact on the care and the quality of patient care. So this evening we want to continue the conversation about quality, health and care in COVID in this pandemic. So Miriam, Donal, Philip and John, it's lovely to see you this evening and thank you. So I'm going to pass you over to Miriam now and thank you very much, panel.
Thanks, Caroline. Donal, it's great to have you here today to discuss quality healthcare in the time of COVID. So obviously quality is quality with a purpose. That is to say, to optimise patient care and the patient's experience of our health service, but also as a means of enhancing staff working and well-being. Quality healthcare also reminds me of Dr. Ira Byock, who was a past president of the American Academy of Hospice and Palliative Medicine and the author of Dying Well, The 4 Things That Matter Most and the Best Care Possible. He recently stated that as clinicians, we are whole persons caring for whole persons. And he talked about embedding in our normal processes patient-centered tools. And as was recently stated by the New Zealand-based The Workshop, in how to talk about COVID-19, narratives to support good decision-making and collective action, it is time to come together and focus on what matters most to us, caring for each other. We will rise to this challenge. We will rise to this challenge as we have risen to other challenges before. Look at the insights, knowledge, and practical help that is being shared around the world so other countries can respond better. So, Donal, coming back to more locally, I was wondering if you would kindly share with us, please, the pandemic preparedness cancer services did for COVID-19.
Thanks, Miriam, and thank you for having me tonight. I think we've been very lucky in Ireland. We've had a very collaborative approach to how we were able to prepare for what has been a very challenging time. I think highlighting what you said earlier, really one of the most important things that has happened is we have tried our best not only to look after our patients but also to look after our staff, and that has really been an important issue that was highlighted probably by the experiences from our colleagues internationally, particularly in Italy and China. We were lucky in many ways to be able to call on some of our international colleagues through the societies that we're all members of to get some insight into how we were going to deal with this. And then I suppose we have been quite lucky in that we haven't seen the surge that we expected. I really think the 3 things that we've been looking at were from a logistical point of view. Obviously, with regards to surgical oncology, we've been able to continue access to theatre through the agreements with the private hospitals, and that's been a huge important area, and required a significant amount of leadership with regards to people actually changing their work practices. And we have been very lucky that all of our colleagues have really worked day and night to try and make sure that those things have remained in place. Also, the staff have been a huge issue because particularly our nursing staff, without them, we wouldn't have really been able to make all these changes. Particularly around the site of where people have been offered treatment, but also in the ongoing interaction with people, particularly around how we communicate with our patients, which has been a huge change, as you know.
Okay. So great, thanks, Donal. So you've explained a lot there from a collective leadership perspective. Is there any other engagement that you had to do to make such changes in a short period of time?
Yeah, well, we had to engage with management at a huge level, at multiple levels, and management have been very much, there's been a can-do attitude. I obviously work in a voluntary hospital setting, but I have to say that the different levels of management, particularly up to the level of CEO, have had an open door policy, and I would hope that definitely in the hospitals that I work in, we've had an approach that all ideas are good ideas, and some of the best ideas have been very simple ideas. So, really, I think that's been the key to the whole thing.
Okay, sure. And I suppose as doctors, as clinicians, how did you get the word out for patients and families?
Yeah, this has been difficult, and I think there's 2 levels to this. There's the fact that there's this there's this fear of COVID, which we'll probably come to talk about in a little while, which is really affecting people's decision making. And we have to be very careful that we've been able to reassure patients and families that if they come to the hospital, they will be safe, and that's an ongoing challenge actually. And we've been really, I suppose, from an oncology point of view, you're totally dependent oftentimes on your clinical nurse specialists who often have a very close relationship with patients and their families, much more so than the medical team sometimes, who have been able to reassure them. And we've also done a lot of work trying to liaise with GPs, again, trying to give patients that reassurance that if they do come for treatment, that they will be safe. So I don't think the actual rationalization or change of how we deliver care has had a big impact on patients. It's actually been that fear of interacting with healthcare that has been a big problem.
Sure.
I think
Sure.
and that's something we really struggled with at times.
Sure. And how have you addressed that, or what? Obviously, you're having to make a lot of change. How have you addressed that fear, or what do you suggest we do?
Well, yeah, I think we are starting to, like, we've had various like everything, we've seen various different reactions to this, but I think coming back to the introduction there, cancer patients do feel isolated, and I think they are, particularly those who are on active treatment, they are very scared, and possibly they have a right to be. But the longer this is going on, the harder it is getting for them to actually continue to have what would we consider a relatively stable social kind of existence. So some patients, I feel, from whether it's coming in for an operation or having their treatment, are very kind of happy to get out of the house, but others are finding it very difficult. And that fear is really something that we're trying to overcome. I think in many ways it's an ongoing piece of work. At the moment, we're reassuring people that when they come for either treatment or surgery, they're coming into a COVID-free part of the hospital.
Yes.
And we're all going to have to live with COVID going forward, and that's just a way of how we educate people. In general, I have to say people are becoming more recipitive of that, but they are still very wary coming to the hospitals.
Sure. And I suppose great, and you kind of touched on that already. As we're moving from the kind of post-acute COVID phase into a more as we're moving from the acute phase into kind of a more post-acute COVID and chronic phase, and I suppose it's unclear how long this will last. I think it's reasonable to say, exactly as you were describing, that we're all concerned about obviously our patients who have COVID, but with non-COVID medical conditions, and the importance, as you were describing there, Donal, about how important it is for them to access timely medical care. What do you envision will happen for ongoing cancer care provision?
Well, I think you're right. We're just going to have to find a way to live with it, and this is going to be a medium and long-term issue. I think from a practical point of view, we're going to have to change a lot of how we provide our services, and a lot of it will have to be provided remotely. In a cancer perspective, I would say things like surveillance, post-treatment surveillance, in all its old-fashioned way of putting lots of people into a clinic and seeing them on a weekly basis, it will no longer happen. And as a result, we're going to have to change how we communicate with patients. And I think that's going to be the biggest challenge, actually. How we figure out how to, for example, break bad news in a compassionate, empathetic way over the phone. There's a whole body of work to be done there in retraining everybody from the very top down to the fact that we probably have to retrain society. And I think that's a big issue that we're going to have to overcome. On a practical level, we have to really get the message out there that if people have worrying symptoms, they need to contact either us, their cancer care providers, or their GP, and they need to be reviewed. And I have numerous examples, even today, of patients who are presenting with advanced cancers who have been symptomatic for a number of weeks. And I think that's only going to become more and more clear in the next few weeks. It's going to be a big challenge.
Yes. Okay, thanks very much, Donal. We'll come back to that more in the Q&A.
Okay.
Thanks a million. John?
Thanks, Miriam, and thank you, Donal. And it's my pleasure to have a chat this evening with Dr. Philip Crowley. And Philip, I suppose, quality is the theme of this evening's talk, but we've had no shortage of examples of quality here over the last few weeks. And I think, as Donal and Miriam have been talking about there, quality is very much situational in terms of responding to, the challenges that any context throws up. And I'm just wondering what examples of quality and quality improvement you've been seeing around the place. I'm sure you've heard lots of things.
Yeah, thanks, John and Donal and Miriam, and thank you to the RCSI for including me this evening. Yeah, I mean, I think it's just so much has changed. We're doing so many things differently. Donal's already outlined a number of examples of that. That all amounts to quality, because it's reacting to a situation and maybe not using the traditional quality improvement methods that we've used, which would be like a small test of change and then see if that change works. Instead, we're introducing large tests of change. We're cutting a lot of corners. We're going right out there. We're changing models of care. And some of it is going down really well with patients. I mean, people are really liking not waiting for 2 hours in an outpatient's. They really like, somebody ringing them at home at an agreed time and really getting the problem sorted. It won't work for all types of care, and Donal's already alluded to a number of examples of types of care that really don't lend themselves to that kind of changed model. But extraordinary, there were 4,000 virtual consultations in March. That'll be massively increased now in April. And we had piloted this as a test of change. We had a virtual orthopedic clinic in Tullamore. Now it's become the norm. I mean, that's remarkable.
Yeah, so there are huge changes, and I think it's probably not just in clinical teams, which I think often get maybe most of the recognition, but I think in support teams and even further back into the centre of the HSE, I think there's probably been a lot of change and improvement. Yeah,
I mean, obviously, one of the changes to the HSE Central that's really striking is that some people actually like us now, which is a very uncomfortable situation, I have to say. Having been, an organisation that gets criticised for an awful lot of things, I'm sure that won't last for too long, so we won't relax too much into that. But yeah, I mean, certainly decision making at this. I mean, I really admire my colleagues in the leadership team anyway. But we've really pulled together. Maybe we've tended to be a bit competitive in the past. We're really working together now. And I commented at a leadership team meeting recently where we were confronted with some situation. I think it was maybe to do with taking COVID care away from general practice and putting it into a safer space to try and build people's confidence in going back to the general practitioner, building on Donal's earlier point. I mean, we came up with the concept of community assessment hubs, and pretty much not only kind of came up with the idea, acted on the idea in the meeting within kind of 5 to 10 minutes, and then moved on to the next problem. I paused and asked everybody to bear with me when I reflected that kind of decision would have taken a year to make in the past, probably a year to pilot, 6 months to evaluate that pilot, to show that it was working, and then probably abandon the idea after that, notwithstanding that it was working. So things, we're working very differently, and it's an example of so many things that we're doing differently that we need to keep doing after this. The virus has done untold damage to our society, but we have to at least take some of the good things out of the way we're working and keep doing them. We can't stop now.
Yeah, and I think one of the important things is calling out these good things that we're seeing and celebrating them as well, and making sure that people get to see, I think, the myriad of good practice that has been developed, and we're using the hashtag at the moment, Our Health Service, kind of to help highlight that on Twitter. But also I think the co-lead team in Ailish McAuliffe's group are also looking for examples of good practice, and do you think that's important, that good practice gets highlighted?
Very much so. I mean, one way to build in good practice into the future is to celebrate it when it happens. Yeah. Like, as an example, we have a team of people working with me in QI. We just totally redeployed ourselves immediately it started. I took on a co-lead public health role for the crisis. Most of my team went into developing a contact tracing system that's now our friends in the north are looking at and trying to replicate. It's not without its problems. Like all massive changes, we have lots of people who've never done contact tracing before doing contact tracing around the country. We have a whole new training program to train them up, and it's kind of part of what builds a bit of hope that we can keep control over the spread of this virus, that we've been able to invent new ways of doing these things, and indeed, John, celebrate them.
Yeah, I suppose one of the things I'd be keen to maybe explore a little is some of the reasons why these new practices are able to kind of come about and flourish. And I suppose some of it is just, people respond in a crisis to leadership, but I think there's also probably good examples of collective leadership, and I think Jonal mentioned this earlier as well. Again, good ideas, coming from staff, listening to people, allowing good ideas come forth and have a go.
Absolutely. I think the fear of failure has reduced. When you're an organisation that's criticised a lot, you second guess yourself a lot, I think. And it's not that we were undecisive, but certainly there's a strong sense as well, I think, of people pulling together, of kind of hierarchies flattening, of egos being suppressed or done away with, even, God forbid, and therefore then, potential for collective leadership. And the idea that, Donald's referred to some of the clinical processes that they've totally revamped. We now have possibly hundreds of pieces of clinical guidance and advice now available on a website that have been developed more or less overnight, and that's allowing people who are involved in care design the care, and that's something that we've always aspired to, and maybe it's been a little bit patchy, but it's right to the forefront of how we respond to this pandemic, and that's certainly something we need to hang on to.
And just to pick up on again one of Jonal's points there, just about that idea of the kind of equal responsibility that senior leadership and management has to looking after staff, as much as it is responsible for looking after patients, and that it's very hard to look after the patients if you don't look after your staff. And I think that's very much, been apparent in this crisis.
Well, I think that's, it's the old, as in one of the hotel chains in America, CEO asked, how do you look after your customers so well? And they said, well, I don't. I look after our staff, and they look after our customers. And clearly that's at the core of QI, and it's the core of our framework for improving quality, which is something that has helped guide us, I think, a bit in this pandemic. But yes, obviously we must look after our staff. People are going to get worn out. This is a marathon, not a sprint. So we need to look after people. We need to try to make sure they retain some kind of work-life balance, that they take some time off. But I think this whole spirit of collaboration has made even the more intense work that we've all been doing easier to do, because there aren't people pulling in the opposite direction. We're pulling in the same direction. And an example of that is in a lot of the training that we've done it in partnership with the RCSI, and obviously this has been hosted by the RCSI, and it would be remiss not to mention the extraordinary collaboration we've had with the RCSI in developing the contact tracing machine that we have in place now, and the other universities have been wonderful as well. I think it's been really striking, the type of collaboration that we've always had, but it's really ramped up.
And Philip, I suppose just to maybe change direction slightly in terms of, Miriam alluded to it earlier, that we're in a long-term relationship now with COVID, and it's likely to have implications, for the months and even, possibly longer. But, we also have to deal with, I suppose, the backlog of suspending the health services operations as normal, and then potentially, coming back to a society or an economy that is changed as well by this. And how do you see, some of the lessons that we've taken in leadership from the current crisis, but also, how do we use quality improvement ideas to help us, get out of this and come out the other side?
Well, one of the things we have been doing already, and I think we certainly want to continue to do, is to use measurement for improvement approaches to just working out where we are. Trending data over time, checking, for example, there's been a bit of talk about the border counties being, having a high rate of COVID illness, and therefore isn't that to do with different approaches, public health approaches, different sides of the border? And various individuals have weighed in on that issue. We did a statistical process control chart looking at the rates of COVID illness across all the counties in Ireland. And the only statistically significant outlier was Dublin. Cavan is not a statistically significant outlier. So there's so many uses we can put the kind of techniques that we use in normal times to bring them to bear in these more challenging and difficult times. So I think part of at the core of our framework for improving quality is being clear about governance. That's something that is often at risk when you're in a crisis and everyone's kind of slightly rushing around and we're doing new things, and people can tread on each other's toes a bit. So it's always good to come back to some of the basic principles of good kind of process, good management and good governance, just to make sure that we look after each other as well, make sure people's roles are clear. And I think that'll guide us to the next phase. But certainly measurement will be key, because we need to watch what was a very significant reduction in normal business, if you like, particularly late March, early April. Some of that's beginning to return. You can see more ICU beds are now occupied by non-COVID patients than were 2 weeks ago. General practice is reviving. It had become very quiet. So we really need that to come back, and Donald's already made that point. And otherwise, what he described, people are presenting late with cancers. That's something that we must overcome collectively, with very clear communications, with separating out COVID care from non-COVID care as best we can, and giving people reassurance that they're safe to come and see us, as they always have been, and that we look after them very well.
But I think we've also seen, kind of maybe role changes happen, and as nursing roles have maybe advanced or taken on new tasks and duties, or the introduction of new practices like video consultation or telephone consultation. Do you think some of that is going to become part of the way forward for our new practice?
Well, I think, I don't think any of us on the call here or people listening think that this virus is going to disappear anytime soon. And I think we're a good deal away from a vaccine. So, yes, I think many of these things should have been part of our practice anyway. Yeah. There are a lot of review clinics that you could run virtually that would be more efficient, way better for our patients, and decrease the carbon footprint of the clinic as well. So all good, nothing to lose there. Obviously, there's lots of other things, parts of our clinical practice that we simply cannot run in that way. So we have to make them safer, so as we make sure that we reduce the possibility of acquiring infection when people come to our services. Yet that's been something obviously we've been working on for years. Healthcare associated infection is something we've been combating for years, and this has upped our game. So we probably have to keep our game up for a long time, and that's a game that we should never lower. So yeah, I think we will use all of our QI knowledge and skills to develop good processes, to facilitate people working together in different ways, to test new ideas, because there's no evidence base for any of this. So that evidence base is just evolving. So we need to use QI methods to test what we're doing, make sure that what we're doing works.
Super, thank you. I'm going to hand back to Caroline there, but also maybe to Miriam and Donal if there's any comments, and then we'll see maybe if Tina has some questions for us.
Jonah, would you? Is there anything you'd like to? Or would we go to questions first, Caroline and Tina?
Yeah, if you've nothing to add, Donal and Miriam, we can go straight over to Tina, please. And just to see, Tina, have you any questions from our audience this evening that you might want to give to the panel, please?
I have a lot of questions and comments coming in. So thank you everybody for that. We're busy typing away. And I suppose people are reflecting on how the services have changed in terms of delivery, how roles have changed within healthcare teams, but also how relationships have changed between the professional groups and management. And a couple of comments there when Philip mentioned the can-do attitude that would stay after the end of this acute phase of COVID. So I suppose there's two kind of questions, one for Donal in relation to cancer services, because we've spent a lot of time over the last couple of years centralising cancer services. And now we're kind of talking about a new model, or are we talking about a new model which will be centralised but slightly decentralised at the same time? And does Donal have any views on how cancer services might actually be reframed and restructured? And the second question then for Philip is around this idea about sustainability going into the future of some of the really good practices and the social contract that we've had with the public around introducing some of this change. And is there a difference between quality improvement and change? Or is the change just being driven by the necessity? And is that the same as quality improvement? And do we want to again kind of reframe that kind of the difference between those, or is there a difference between those? So it might go to Donal first for just that idea about what might the future of cancer services look like? Is it going to be a more distributed model?
So I think, I think actually it'll probably be a more centralised model, to be honest with you, and it'll hopefully be even more patient-centred. I think I agree with a lot of what Philip said earlier. This is an evidence-free zone, but I would also argue that a lot of the evidence we have in cancer, where we have randomised trials that maybe show 4 or 5 months progression-free survival benefit, were not performed in the setting of a pandemic and really don't probably matter that much in current circumstances. And maybe that will allow us to rethink exactly what is quality of cancer care. I think from a surgical point of view, it will probably drive more centralisation, and that's probably a good thing, to be honest. But from a systemic therapy perspective, it may well be that the systemic therapy will be administered throughout the country in a well kind of quality assurance in a quality assured manner. I think the biggest change that you will see actually is, coming back to my point, is all of this surveillance that is happening, which again, I liked Philip's point about the carbon footprint, where people are being brought up for regular radiology in particular for cancer surveillance, where there is absolutely no evidence at all to support it. In fact, all the evidence would go against regular radiology for the vast majority of surveillance in cancer, both patients who have maybe been off treatment, but even on treatment. So I think the key here would be actually to use this opportunity to really develop a proper patient involvement in how we refashion cancer services going forward. And one of the things that would be very helpful would be to actually really put a proper patient perspective into what patients want, because that will allow, this is an opportunity to make things work properly. So I think that's where you're going to see a real change. But I do think it would be appropriate to see more centralisation of surgical cases.
Okay, thank you, Donal, for that. So Philip, I might go over to yourself then to talk about sustainability, and there's still more questions coming in about what kind of tools, quality tools, are being used at the moment, as well as the general question around how you see this going forward. But are there specific tools that you think are particularly useful in this situation?
Well, we certainly doing a lot of process mapping and using lean to try and, when we're developing entirely new processes, we're looking at a process and we're trying to make it more efficient, particularly around the contact tracing testing machine. So we've used a lot of lean there. And in terms of kind of sustainability of good practice, that's always a good question, because I think, as we all know, it is easier to make an improvement than to sustain it. People move on to other things, they lose focus, they lose concentration, they focus on the next big idea. So I think sustainability is a big thing to consider. We must sustain the things that we started to do that work better than they used to. We must, and one of the key drivers of that, Donal has laid it out very clearly, are patients. Because if patients like it better, they will be our strongest advocates for, as you say, maybe decentralized chemotherapy and decentralized follow-up clinics, maybe virtual follow-up clinics. And then course, I think everybody's up for centralised specialist care. That's the best way to deliver it. So I think building patients in, they're one of the 6 drivers in our framework for improving quality, will be a key driver for sustainability. But I think there is an exercise now to look at recovery in the HSE, and very clearly part of that is hanging on to what's now working better, and not just going back to the old ways of doing things. And then the question around QI and change is a very interesting one. I mean, change that produces improvement, I'd certainly like to then bag that and say that's quality improvement. But change that doesn't lead to an improvement, then I'd like to distance myself from that and say that's nothing to do with quality improvement. The truth is that not all changes lead to improvement, and not all good ideas work, which is why we test them. So yeah, I mean, I think QI is a kind of a bolt-on to change, and it helps us just take stock of the change. And if you like, some of our more considered approaches to using the QI methods we haven't really had the opportunity to use some of them, except for maybe some of the lean methods. But we have kind of adapted them to this concept of test something, try it out, and then stop it if it's not working. And that's one of the key things I've said to the rest of the leadership is, look, we're not in a methodical phase here. We're not in a kind of a deliberative phase. We're in an action phase. We don't have time to be cogitating too long on things. But what we do have to do is keep an eye on things, keep measuring them, and stop them if they're not working, or change direction. So that's very much at the forefront. And that's like a condensed approach to QI, I think, in a way.
And can I just ask a follow-up question there, Philip? Because Siobhan has asked a question around the pandemic shifting the focus of practice of QI from that of reducing variation, which is really where we focus a lot on QI at the moment, to increasing adaptive capacity. Do you think there will be a kind of a mind shift in quality improvement, or do you think there's space for everything? It's just where we're at in the.
Well, actually, that's a really good question. Variation that's creative and useful is great, so long as it leads to better care. But clearly, all the work we've done over the years that has identified variation that's not based on different types of patients, was really based on different approaches, some of which work better than others. That's the kind of variation we will always need to reduce, just to bring everybody to the best standard of care. So standardizing to good standards, like cancer care, has been at the forefront of that. But that doesn't preclude adaptive change. And certainly a core, collective leadership is built on small teams at the very front line, improving their part of the process. So a team with where the porter, we've done this work where porters have radically changed care at the front of house, where security staff have had ideas about how we interact with patients when they come in first, where practice nurses and general practice have come up with the ideas, where reception staff have come up with ideas. Adaptive change has probably accelerated, I'd say, in this somewhat frantic environment. And that's good. So we need to keep it accelerating because all the good ideas come from the front line anyway.
Okay, great. There's just one more there for Donal, and I suppose there's a question in there as well for Philip. And both of them are talking about research at this point in time to support the evidence base. Are you aware, or are there plans? Or how are you gathering information and maybe publishing that so that we capture this kind of evidence base to kind of inform decision making going forward? So the question came in specifically for Donal, and it was around getting the patient perspective. Is there a way that we can even start researching that and gathering evidence at the moment?
Yeah, we're actually gathering it, and it's interesting. What I was going to say. The one thing that patients want is access. The biggest fear they have if we change this model of care is that they will not be able to access it when they need it. And our initial data would suggest that about 80% of people who come to outpatient departments in particular don't need to be there. But the reason that they're coming there is to make sure that they have an access in if they do need that, a way in the future if they need it. And to me, that's very powerful. The other thing that was very powerful is we've gone through a very difficult, lean process within our own department here in the Mater from a gynae cancer perspective over the last year and a half. But we did bring patients in, and patients told us that the most stressful period of their cancer care was a time that they were waiting in an outpatient room to be called in to see a doctor, to be given the results of their scan, or to be given results. And most of the time, as you know, those results are negative, and it was this really difficult period of time for them. So we are collecting that data now. I think that publishing that data is interesting. That will all be published, I suppose, through different sorts of quality journals and patient improvements. But one of the big things that I think we need to really come back to is the idea of having patient focus groups, so that we can actually figure out the best way to ask these questions, because that's actually one of the biggest problems. Most of the tools we have to measure this sort of thing really don't measure what we want to measure. And I think long term, from a cancer perspective, one of the things that will be very clear in this will be that the standard quality of life measures that we roll out time and again for particularly clinical trials really are of little benefit when everything is turned upside down in a pandemic situation. So there's going to be a big role of work in how we employ technology to collect real-time information, because particularly in Ireland, I'm convinced that Irish patients still want to please their doctor, and they're much less honest with you in person when you ask them to fill a questionnaire than if you can contact them, as we've been trying to do on a Wednesday morning when they used to be dropping their kids to school and it's raining and things aren't maybe as good, and they're not putting on their best face. So I think that's where we're focused at the moment, and how we get real-time information back and forth, and some of that will be down to technology, but also down to how we change those tools.
Okay. Yeah, maybe to add to that, Tina, yeah, it's a really good question again, because again, when you're really busy, the danger is you just keep doing what you're doing. You don't reflect, you don't document, and then nobody else can learn from what you've done. You haven't measured where you've come from, where you've got to. So there's a huge amount of measurement going on. The HPSC has been trailblazing a lot of that. And so we can point to the impacts of different measures, how long it's taken them to impact on rates of disease, rates of hospitalization, rates of ICU use. Equally then coming back to research, pure research projects, a number of us are co-contributors to a number of significant now funded COVID-related research projects, which hopefully will again be accelerated research, because one of the things about research is it's wonderful and I love research, but it takes a hell of a long time, and translating it into tangible differences for patients takes sometimes even longer again. So we'll be hopefully developing a model of research that's way more agile. And some of it will be looking at technology. So we'll be looking at, we're very much supporting new ways of kind of measuring vital signs and documenting them, and wearable devices as well are possibly a thing that we're supporting, and may become way much more part of how we support people manage and help people manage themselves. And like we do a lot of work with patients in the QI team. So we have 2 patient reps on our management team. So we've been talking to our patients as well about what we're doing, and they've been giving us feedback, real-time feedback on how we're doing and things that we maybe haven't considered and things we need to think about.
Okay, Caroline, there's loads of questions and comments, and people just thanking both Philip and Donal, especially this evening, for sharing all of that with us. So back over to yourself, Caroline. Thank you.
Yeah, thank you so much to the panel, and it's very hard to summarise some just key takeouts for our very rich discussion this evening. But some of the main things that we've been picking up are the post-treatment surveillance that Donal talked about, and the involvement and the benefits of technology, and also the centralisation of services to reduce the footprint, specifically in relation to radiology, and other centralisation of services. And I think the big thing we took out of it as well was the involvement of the patient, and while the patient is critical in the decision making, because the service is there for them. And Philip reiterated that is a major component of the quality improvement process. And also the point about involving the staff on the ground, who have some some great ideas. Philip shared a lot about the hierarchy flattening in this COVID crisis and how that decisions had to be made terribly quickly. And the urgency of these decisions mandated that people worked very much more collectively together and didn't have time in terms of testing out the introduction of new care models. So the speed in which that has happened is remarkable. And in the doing of that, the challenges going forward for the HSE is to look at how can we hang on to these really good practices and sustain them in the recovery. And the HSE have started to look at that and to align that to good quality practices where we can measure that and we have evidence of that. And also talking about into the future, you know, the significance of research around COVID and the fact that the HSE have engaged with a number of very significant projects, and while research is wonderful, that, you know, the nature of it sometimes is quite long, and you know, that's really we're trying to speed that whole process up in terms of not losing the quality of it. I think the other part that was really interesting, which feeds into our conversation next week, is the whole thing around looking after our staff and all of the research. There's decades of it to support. If we don't look after our staff, we're going to have probably not the greatest impact in terms of the care of delivery for a patient for a whole load of reasons. And that is fundamental and underpins the whole quality process perspective. But also I think to think about looking after ourselves. So there's the whole self-compassion piece as well. So everything is aligning to our next conversation next week, which again is staying with the theme of quality, but looking at a person-centeredness approach and looking at organisations that take care of their staff. And the research will show you take care of your staff, you have a highly performed team who are engaged, and you have better patient quality outcomes. So I'd like to just thank our panel and invite people to our conversations next Thursday on the 7th of May. And we are going to be looking at person-centeredness organisations that take care of their staff in COVID. And additional supports are available through a series of videos from Professor Michael West, who is kindly going to lead out on a leadership lecture on the courage of compassion in this crisis, leadership for now, leadership for the future in the healthcare. And we would like to thank all of our panel very much. And if any of our audience will have any more questions, please submit them to RCSI leadership@rcsi.ie. So thank you very much, everybody. And we look forward to seeing you and inviting you back again. Take care.
Thank you.
Thank you.
Good night.
Good night. Thank you.